Peace, this is Atan Thomas, and you're listening to WPFW Washington, your station for jazz and justice.
Go tell it to the nation on Capitol Hill and everywhere. Go tell it to the nation. We all deserve health care. The greedy corporations determine who survive. Can we give just the wealthy the right to stay alive? Go tell it to the nation on Capitol Hill and everywhere. Go tell it to the nation. We all deserve health care. In hospitals and clinics, the poor are turned away. The system won't provide for the ones who cannot pay. Go tell it to the nation on Capitol Hill and everywhere. Go tell it to the nation. We all deserve health care.
And welcome to this 2-hour special. We are talking from 6 p.m. to 8 p.m. on reversing the healthcare crisis for the underserved, a radio forum on Unity Healthcare Clinic in DC. This is a 2-hour special co-sponsored by WPFW and the Union of American Physicians and Dentists. And we're going to introduce the speakers coming up and the topics we're going to be talking about. But let me just first introduce myself. This is Joni Eisenberg, longtime WPFW host. You can hear me usually on Mondays, 10 a.m. I'm a longtime healthcare advocate, and that's what we're going to be talking about today, how the healthcare system is broken and needs to be fixed. And I am thrilled to be joined by our co-host today, a community activist, Dr. Rhonda Hamilton. And Rhonda, please just give a brief introduction. Who are you?
Oh, wonderful. I am a mental health advocate with Healthy DC and Me Leadership Coalition, as well as Am I Mother's Keeper, boots on the ground in the district for well over 8 years. And I, too, am alarmed and concerned about this Unity healthcare crisis going on in our city. So, Joni, thank you so very much for allowing me to co-host with you here today.
And we're thrilled to have you. We're having a little bit of technical problems today here, but that's not unusual for this situation in this United States and this city. But we do the best we can. If people can't hear me, somebody let us know. But the first part of the program, we're going to be giving a brief history of the Unity Clinics, of, first of all, the founder of the Union of American Physicians and Dentists is going to introduce the program, the story in a moment. Then we're going to be having a brief history of Unity Clinic. It's back when it first started. Then quickly after that, we're going to be hearing from the front lines, a description of what's happening at Unity and the community clinics. We're going to be hearing from some of the physicians and some of the patients. We'll hear a little bit as well about the homeless services that Unity provides. The second hour, we will be talking about the DC jail. That is also has health services under Unity, and we'll spend the last half hour talking about what is to be done with this challenging situation. What can the community do, and what should the DC government and the DC elected officials be doing? And hopefully we have on the line Dr. Bussey, who is calling in, hopefully from California. He is the president of the Union of American Physicians and Dentists. Good afternoon, Dr. Bussey.
Oh, good afternoon, Joni. Can you hear me?
Yes, I'm so thrilled to hear you because we're a little challenged here in the studio.
Well, that's okay. We're only 3,000 miles away, but we're unified in spirit.
Absolutely.
And I feel the same way you do.
Yes, you do. I'm thrilled you could be with us to kick off this show today. Well, first of all, tell us about the Union of American Physicians and Dentists.
Okay, well, our union was founded in 1972 in San Francisco by a private surgeon, Dr. Sanford Marcus, who was tired of the regulations and the HMOs that had just been coming onto the scene in the 70s and 80s that were, quote, managing care. He was kind of a renegade curmudgeon, sort of like I am. He wanted to preserve the doctor-patient relationship and not have third-party interferences from, HMOs, insurance companies, and administrators. And over the last 30 or 40 years, there's a graph that shows these administrators have multiplied by 30 times, 3,000% in population, while our providers only 1.5 times. So healthcare is being inundated by people who don't have medical or other health degrees who are dictating how we practice medicine. So our union has organized into about 7,000 providers across the United States, including D.C., New York, California, to do contracts and collective bargaining with the employers to make a more just level playing field with our doctors to have a greater voice in their health care and how they deliver health care, and as well as improving their salaries and benefits. In a nutshell, we are a union just like any other union in this country.
And you are the union that represents the largest number of physicians. So that's quite important.
Largest number of postgraduate. There's resident unions bigger, but as far as after residency, we're the biggest.
Okay, great. And I know you also are very concerned, as you started to mention, about the crisis of the increasing corporatization of healthcare in this country. And that's partially reflected in what's happening at Unity. So we're going to have some of the Unity providers speaking in a moment, but tell us briefly what the crisis is in Unity and how it relates to really the corporatization of healthcare.
Well, like I mentioned, when you have people who are multiplying like rabbits, and I'm talking about the administrators, they need to manage. Back in the 1800s, there was a man named Frederick Taylor who went to Bethlehem Steel one summer and watched how people did their work and wrote a description of how they worked and how they should be working efficiency. That was the beginning of middle management. And middle management, like I said before, has come to medicine in the last 40 years. And it has interfered with Unity in several aspects. That's the corporatization. I call it the industrialization of medicine, the assembly line nature of it. So there are about 5 different points I want to bring up briefly here. What Unity providers want to improve their life and the patient's health care in conjunction. Number one is transparency. Financial transparency will be gotten by this collective bargaining, where the employer will hopefully answer our questions on, whether they're broke or not. We don't think they are. We want our members to be paid fairly so they can rest easy, take care of their own lives, and stay at Unity. Many people have left in the last 6 months. Dozens of providers have left. Whatever the reason, too much work, too little pay, this kind of thing, that's not good for the safety net of Washington. We would like committees, joint labor management committees, to make suggestions, including our doctors and nurses and health providers, along with the management, about policies, about equipment that they need, medications that should be on the formulary. One example I have in what unions have done back at Boeing over in the West Coast, they had an assembly line where they made the 777 airplane. It took them almost a month to make it. Management would not listen to the people on the ground on the assembly line, but after a while they finally did, and all the efficiencies that people on the ground had noted improved the efficiency of making that airplane to the point of where it went from 28 days to 10 days. So listen to your people on the ground, listen to the providers, and you'll have a more efficient and happier group. The second area is safety. The members over at Unity want a more safer environment to work, especially our female providers, some of whom work in the jail. They don't want to live in fear. They don't want to be spit at. They don't want to be assaulted. They don't deserve that. They're good enough to work in these facilities. They should be taken care of. The third part is time. Time and money are pretty equivalent nowadays. Time is precious the older you get. I can tell you that right now from my perspective. But they would like administrative time off. They want time to research some of the problems that their patients have, do emails back and forth with their patients, communicate with them more, and just take a break from all the workload that they have. Some of the providers are seeing more than 20 patients a day, and these 20 patients have multiple problems: inflammation, diabetes, high blood pressure, cancer. It's not fair to the patient to put them in and out like an assembly line. We're not widgets. This is not a automobile factory. Patients are not automobiles to be made, okay? So the providers want more time to digest these patients and fewer patients per day to do a better job of it. And lastly, we want continuity of care. We don't want all these dozens of providers leaving. They want to have a happier and healthier environment. You know, the burnout rate, you hear about burnout and provider burnout. Physicians are now have the highest rate of suicide of any occupation in the United States, over 400 per year. This could be solved by a happier environment, because a happy doctor, a happy provider they give you a happy patient. So in a nutshell, those 5 things: transparency, safety, more time off, fewer patients, and continuity of care is what the providers are seeking. And unionization and collective bargaining, we feel, is the way to get there.
Physicians are now the highest. Okay, you just heard the president of the Union of American Physicians and Dentists. We're going to move right ahead. Thank you, Dr. Bussey, for calling.
Thank you.
From San Francisco, from California, and we're going to come right back here to Washington, D.C. and talk to our people here. We're going to do a brief history of Unity with Dr. Edwin Chapman, and I'll probably jump in myself on this one. And then after this history of Unity, we'll go right to the provider. First, and then. So, Dr. Chapman?
Hi, Joni. Can you hear me?
Yes, we can hear you fine.
Thank you so much. Unity Healthcare has been around since, initially in 1985. It was really started by Dr. Jesse Barber and Dr. Janelle Getches, who co-founded what was then called Healthcare for the Homeless Project. Dr. Barber was a pioneer, not only as a neurosurgeon, but he was a community activist, and he was involved in everything in healthcare in the District of Columbia, including past president of the National Medical Association, the local chapter of the National Medical Association. So he was very well respected. And when he wanted to do something, he did it. And he saw the need to bring healthcare to the homeless. So that's how it got started in a very small facility. They subsequently began treating patients in CCNV, the Community for Nonviolence, and they set up a clinic there. That was the largest homeless shelter in the District of Columbia, and that clinic was actually run by a good friend of mine, a nursing instructor from Howard University who faced a lot of opposition in the 1990s, but that became the first nurse-run clinic anywhere in the city, and that was in 1992. She got pushback from the faculty initially, but W.K. Kellogg came along and gave them a $1.4 million grant So that was really the start of the whole process. Now Unity has about 20 sites around the city, as well as the DC jail under contract with the district government.
And I'm going to jump in because Dr. Jesse Barber, who I work very closely with quite a number of other community activists, he's the one who convinced a bunch of us to start this radio show back in 1992. So he's definitely very, very much a part of who I am. And and I was actually on the first board of directors there with Jesse Barber and Dr. Gedges when they first started healthcare for the homeless. Just 1 minute I'm going to spend. The Upper Cardoza Clinic, which is one of the clinics associated with Unity, actually has its own history dating back to the 60s, related to Dr. Barber's mentor, Dr. Paul Cornelli. But that's a whole nother story. It's just suffice it to say that Unity has an important history, and it needs to be supported so that it can continue to serve the community. We're going to jump now into speaking with some of the providers. And hopefully we have on the line now one of the Unity providers involved with unionization is Jimmy Tracy, who's a nurse practitioner, and Dr. Rivas. Jimmy, are you on the line?
Yeah, I can hear you. Hello, Joni.
Terrific. I'm trying to do about 5 things at once here. So tell us about what's going on from your perspective at Unity, particularly in the clinics, and how it impacts you and how it impacts the patients.
Well, I'm a nurse practitioner. I've worked at Upper Cardozo Clinic for the last 11 years, and I've been there for 11 years because the patients there are wonderful. I wouldn't want to work anywhere else, anywhere. And so I want to stay there. I've stayed there through the pandemic, never took a day off. Me and Dr. Rivas and others worked every day through the pandemic, making sacrifices. And it's just, and I'm still there in spite of all the challenges there. And I think that it's just a place with a wonderful, diverse population of patients who we want to take care of in the best way we can. So that's where I and a lot of my colleagues are coming from. But since the pandemic, couple things have changed, not just for us, kind of our sense of ourselves as providers, and but also, the healthcare is changing, and things like telemedicine have brought changes. Just people's relationship with healthcare, and I think that there have been
example of what some of the challenges that you face in serving.
Yeah. So, well, actually, so sorry to I keep bringing up the pandemic, but it was a big moment. You think about how things have changed since the pandemic. For example, we have these life-saving vaccines that come into existence, which is wonderful, and we were able to help provide that. But this is the kind of thing that didn't exist. Or a few years ago, we didn't have COVID. We didn't have COVID vaccines. We also didn't have quite the level of vaccine hesitancy in our society. Well, that's just another thing on top of all these other things that we as providers have had to do, right, for patients, whether it's controlling chronic conditions, their acute problems. But on top of it, it seems like every year there's more and more that we need to do for patients, which is great because we love the patients and we love doing the work we do. But it takes more time to do those things, to talk to people about the safety of vaccines, for example. And so it's just another example of the way that we want to do the work. We sometimes don't have the time or the working conditions to be able to do that. And so it kind of comes into sort of the story of our unionization effort really is about improving working conditions for providers, not just to make it safer, but to allow us to fully realize the goals of primary care, which is to create relationships with patients, to engender trust, to create good health outcomes. When we're just trying to see as many people as possible, obviously that just feeds into sort of the broken healthcare system that already exists. And so what we're trying to do, instead of being another group that seems to complain about the healthcare system being broken in America, I feel like as a union, we are actually trying to do something about it. Like Dr. Bussey said, we're trying to bring to bear the wisdom of healthcare providers on the front line in order to help to create, in our own little way, a better, more just, and more more functional healthcare system.
Excuse me, I'm sorry to rush you, but we have
Thank you.
But just hang in there with us. We'll be coming back to you. We'll be having more discussion. But if we have Dr. Esteban Rivas with us, physician in family medicine.
Yes, I'm here. Hello.
We're a little handicapped tonight. I can't tell who's here, but welcome. Tell us about who you are and what your situation is like as a physician in family medicine at Upper Cardozo. What are your challenges?
Yes, well, I've been with Unity for about 8 years now. I came here as a resident. I did my residency at Unity Healthcare. Did 3 years of residency and then stayed on as an attending after I graduated, because at that time, I believed in the mission that Unity was portraying about helping the underserved, helping the homeless, providing the safety net resources for the community. But as Mr. Tracy was saying, after COVID, things have really changed a lot, and we've been met with an administration at Unity that is unwilling and incapable of really meeting the expectations that we need. They are very focused on visits per hour. They're not really focused on preventative medicine. They keep saying that they are focused on access to the clinics. However, more and more people are leaving. They're not hiring many people because of the HR department not working properly. So we are forced to see more and more patients. We are asked to put on more and more on our day-to-day to do more. And that's what Dr. Bussey was trying to say, is that we need more time to actually treat our patients, to be able to give them proper care and to have proper access to good preventative medicine. I know that Dr. Boyd talks a lot about trying to have access, but they're very much focused on what is called not preventative medicine, urgent care kind of style of medicine. They don't really focus on the continuity of patient care. They don't really care too much about that patient doctor relationship. And it's been a really struggle trying to get them to the table. They don't really want to listen to us. During our meetings last year, they would block all comments from the providers. They wouldn't let us comment on anything that they would say. So it's a really big struggle that has been going on for a couple of years now. And it's really sad because I did stay here because I really wanted to treat the community. I am part of the community. I am an immigrant. My parents immigrated here. I'm a first generation. I want to treat these population, these patients, but it's really, really hard when the administration is making policies that go against what the mission of Unity is and what the mission that we as providers want to do.
Okay, and I understand something like 25 or more physicians have left since the beginning of the year as a result of some of these challenges.
Correct. And last year, when Dr. Cox was here, she made a presentation and had mentioned that about 14 providers had left. So those 14 plus the 25 that have left this year have really made a big dent on the amount of providers that we have. We essentially have about 20, if that, full-time providers in the whole entire of Unity that see more than 90,000 patients in the whole city. Which is it's a lot of patients. The AAFP recommends about 2,000 patients per provider. Right now we're seeing like 4,500 patients per provider. So it's a lot bigger than what the AAFP recommends for like a safety patient doctor ratio.
Okay, and before we close out the hour, we're going to have time for some of our co-collaborators here, activists in the community, to ask questions. I believe we're going to have Ambrose Lane, Roach Brown, and Timon Freeman, others, as well as Dr. Chapman and Rhonda jump in before we finish up this hour. But before we do that, I believe we're also going to hear from the physician who works with homeless outreach. And Dr. Emma Delp, are you here with us?
Yes, I'm here. Thanks for having us, Joni.
You're welcome. Thanks for being here. So tell us, you're also in family medicine. You work at the Parkside Clinic and the jail. But tell us in terms of what you do with the homeless outreach.
So I'm not actually at the jail right now, just homeless and primary care at Parkside. So with homeless outreach, it's a little bit different than the primary care setup that we have in the clinics. For most of the homeless outreach, which we have over 15 sites throughout the city, which varies from shelters, day centers, soup kitchens, and walking outreach, where we actually are able to go physically to the encampments and serve the patients in the tent or on the bench or whatever. Most of it is just walk-in. So we're meeting the patients that day where they are, and if they need and want medical care. For the clinic, it's a very standardized American healthcare system where patients are scheduled for the most part. We know who we're seeing when we're seeing them. Homeless outreach is very different. We're just showing up, and whoever comes and wants to see us, they're going to see us. The only difference is at CCNV, where they do some scheduled patients, because that's our central hub of most of the homeless outreach. So even though homeless outreach is its own segment within Unity, we still do see these patients in the clinic as well. Like the Anacostia, Parkside, Upper Cardozo, all those central hubs, we do see these patients. So it's just not being done in the homeless outreach setting.
Let me ask you. Can you guys hear me?
I can hear you.
Okay. So back in the day when I used to be working with Unity and working in the health department and social services, and we did work with Unity for healthcare for the homeless and go out into the streets to support the homeless people. Is that still happening?
Yep, I do that actually on Tuesday mornings. So a typical schedule for me Tuesday mornings is I go to the breakfast program at Miriam's Kitchen, where people are already coming to get food and like case management services. When breakfast is done, then I get to go out with one of their case managers to the encampments, to the tents, to the benches, and see the patients there right on the street.
Okay, you're listening to WPFW 89.3 FM. Jazz and Justice Radio. This is me, Joni Eisenberg, who you can hear Monday mornings at 10 o'clock. And my co-host is Rhonda Hamilton. Welcome, Rhonda. We're going to make sure that Rhonda gets a chance to jump in here in a moment. We're going to be next hearing from a patient. And I believe after we have the patient, we're going to get into a more general discussion with some of I'm going to call all of my friends here co-hosts. Let's go to speaking with the patient, Miss Keisha Keith. Good evening, Miss Keisha. Are you here with us?
I am here. Thank you for having me today.
Great. We're glad you could be with us. So you are a patient at Unity.
I am a patient.
tell us what your concerns are, what some of the frustrations are, and I'm sure some of them are related to what's happening at Unity, and some of them are related to the just general problems with the healthcare system, period.
Yes, ma'am. Well, let me just say this, that I know that time is limited, so I'm going to just make a short statement, and I'd be happy to answer any questions, but I'm in this for the long haul to try to support you all. But I wanted to just take this time today to join with the providers and the patients and the folks who really care about the services of Unity by just giving you a little snippet of my perspective and my experience and just the services even that I've received with Unity, if that's okay.
Sure.
So I'll just start off by saying, and just take a couple minutes to say this. I almost forgot until this podcast or until this broadcast happened that I was homeless when I first got with Unity, because I didn't stay with Unity because I was homeless. I stayed with Unity because of the provision of the doctor who I have there, who over for now more than 6 years has been a lifesaver for me. So, but I will tell you that I found out about Unity when I came to Washington, D.C. as actually a law student and a White House intern in 2016. And I'd come here with the faith and a prayer, but I didn't know anybody in the city. But I knew the opportunity to serve the President of the United States was one I didn't want to pass up. And so I came here. And the way that I had a place to stay with very little money, $100 on a credit card and kids back in Chicago, I found a Shelteridge Second and D that allowed me to stay there overnight and said, hey, they didn't even know why I was here, but they knew that I, like everybody else who stood in line there, did not have a place to go, and I didn't have any money. But I got up from that shelter every day and I went to some, I'm sorry, I don't want to get emotional. I got to get this out, right? But I used to go to some and have breakfast, and I knew that I needed to go and find some type of health care because I didn't have any at the time. And I had a chronic health problem that I knew had to be addressed. And so some kind of way I wound up walking into Upper Cardoza, and that is when I first met my doctor. What I will tell you is that even 6 or 7 years ago, before the pandemic even happened, I have to be honest with you, I went there and I met this person. The providers there were always nice to me. And I didn't even realize at the time, I didn't know anything about DC, that they started serving homeless people. But I got care that I felt like was just as good as any other place. So I wound up building a relationship with the doctor that I had. Didn't really talk to a lot of people. DC is a very lonely town. But when it came to my visits, I got attention, I got care, and I appreciated it there. So that's just the beginnings of how I even became associated with Unity clinics. But of course, when things change, and I may have even gotten in a position where I could have gone elsewhere, I didn't want to go elsewhere because of continuity of care. I'm not an inanimate object on an assembly line. I'm a human being. And even having to discuss your health issues with one person and then having to do it with someone who's strange and then having to do it with someone else, that makes people not ever want to come back. As you can probably imagine, I'm a pretty tenacious kind of person. I don't give up easily. I push through hard things and hard times. But I have to say that being a patient at Unity has been a bright spot for me because I never felt like I got less than services there. So even when it was okay and I could move elsewhere, I have never changed my primary healthcare provider. What I will tell you is, though, that I can tell that there's been some changes. Because of time, I will just say very quickly that, to give an example, my last visit, not only did I have to talk with my doctor, before I even got to see my doctor, I went to the walk-in clinic. And it's because an appointment to see my doctor would have taken me to October. Because of my health issues, I can't wait that long to see her in person. But this person, not only did she see me through the pandemic, through video calls, not only did she actually answer my emails, provide referrals, but just in one visit that I had within the last couple months, I literally needed 2 letters. One was for a job. I needed 3 prescriptions. I needed an update in medication. I needed follow-up. I needed labs. These are all things that I came with a talking list, and my doctor helped me with all of those things. But I'm going to tell you, I went to that walk-in clinic and I was there before 8 because that's what they told me to do. I didn't see my doctor until maybe around 12:30 or 1. but I would have waited till 10 o'clock that night because I have a relationship and I appreciate her care. But I noticed that when I walked in, it seemed like everybody was saying her name. And I'm like, wow, like, where are the other doctors at? But I just waited. And this is no reflection on the service providers, because even the reception, she was so sweet and so nice. But the truth of the matter is I was afraid of being turned away. Just imagine the people who don't have the resilience to stick out with the situation and wait 5 hours to see someone. I needed to make sure that you all knew that that was the case. But I got serviced, and I don't know if my doctor even had 12 minutes with me, but I can tell you that 4 or 5 emails followed after, and she's answered every one of them. I'm here to just make a quick statement to say that whatever you do, please listen to the people who are doing the work. Listen to the patients who are receiving the care, because I don't know what socioeconomic level everybody's at or what intelligence or education level everybody's at, but I know everybody's a human being. And I know that the services and the providers there are stellar. And I'm thank God for them, because it got me through a very, very hard time. But I will stick with Unity and my providers there. But I'm very sad and disappointed at any administrative folks that don't remember the persons that you're serving and your mission. And I'll stop with that.
That was wonderful. Thank you, Ms. Keith. This is Dr. Hamilton. I understand your emotion, and we feel it here in this studio. Question that comes to mind is just, what does it look like when the professionals that are hired to care for you find themselves seeking protections and their mental capacities violated, in exchange also violate yours? Who wants to worry about not being able to see their doctor? It's so personable to have healthcare challenges and not know that that relationship is something that's able to be sustained. So thank you.
Well, yes, absolutely. I want to just come in and say to you that we feel it. I don't feel it in the way I'm treated by my doctor or the staff that's there, but I feel the tension. I feel the neglect. I feel them overworked and understaffed. That's why I told you I would have waited till 10 o'clock at night to see them, because I know that they're doing the best that they can. But why would anyone do that? Now, I will tell you, in my field of work, being in social services to some extent and having a longer career in social services, the one thing I will tell you is that if you are traumatized at work, you can't be the best provider. And you lose patients and providers if you all don't get a handle on this and start prioritizing the people who do this very important work. I feel it as a patient. I just stick it out because I don't have anywhere else to go where I would want to reestablish this. I wound up crying one day when I saw some new person who I don't even think was really a permanent person, and they were asking me questions that I know my doctor knew the answer to already. It was frustrating, and I literally cried.
And Keisha, you stay with us. We're going to jump now into a conversation that we have time for from now until the 7 p.m. hour, and I'm going to bring in some of my comrades, my buddies, to jump in here. We have Kimon Freeman, who's on the line, and I want to bring him in a moment. Ambrose Lane, who's heard on Mondays at 5 p.m. Roach Brown, who was heard this morning, Tuesday at 10 a.m. And of course, Dr. Chapman is still with us. We're going to see if they can ask some questions to not only Keisha, but to the 2 providers that are on. And I just wanted to read a quote that Kimon reminded me of the other day. Of all the forms of inequality, injustice in health is the most shocking and inhumane. And that was Dr. Martin Luther King, yes. 1966 in Chicago. I want to give it some time for each, for definitely Kimon and Ambrose. And in the next hour, we're definitely going to hear from Roach Brown as we walk into those jails. Kimon, what is your comment about healthcare in general and the situation? Apparently, this Unity Health Clinic is having a lot of problems. There does not seem to be enough spotlight from the so-called powers that be. There's not enough, and we're going to talk in the second hour about what the community can do and what the DC government and elected officials should be doing. But what is your comment on the situation so far, Kimon?
Well, thank you for having me. This is Kimon Freeman, REACT Radio, DC delegate candidate for DC Statehood Green Party in November. it's disheartening to hear these stories, and as you know, the fatal experience I had in my family with my sister having mistaking health insurance for health care and the profit motive driven business model that America has. But I I really am disheartened because Unity Healthcare has been a beacon for Gap Healthcare in the District of Columbia for decades now. I had a great relationship with the powers that be at Unity Healthcare from 2005 to 2010. We was doing the Black Love Festival where we had the highest AIDS testing rates of any calendar year than Department of Health. We had the highest mobile unit testing rates for 6 years, and Unity Healthcare was instrumental in helping us do that. They was supportive on site and also financially. And then they lost a lot of funding and they start shrinking. And I realized the powers that be wasn't providing the support and the services that they need. And that's across the board. The fact that I cannot say this enough, that DC has the highest maternal mortality rates in the entire nation speaks volumes to where we are and the refusal to provide the type of support and care that is needed. The fact that Black women and Black mothers are at the helm of a city that has the highest maternal mortality rates in the country is deplorable. I ran across a figure here when I was preparing for my comments today. And it says that almost 30% of women who gave birth at hospitals said it was mistreated. I would say it's even higher for Black women, of course. They say when America catches a cold, Black people catch pneumonia. So if it's 30% for all women, it's higher for Black women. But less than 5% of those women say they're mistreated at home. But they make it very difficult to give births at home. And I think that fact right there, that this over 1 out of 3 women feel they mistreated at a hospital, and less than 5% say the same thing at home, speaks volumes to the nature of the problem that we have. I think that when we look at this from a satellite view, I think one of your good doctors said, we see how this is all connected. And as Barbara Roach Brown would say, there's a lot of joogie boogie here. And I think that we need to hold these people accountable, and I'm glad we have forums like this to expose the hypocrisy that is causing deaths of people, and that this is not just mere dollars and cents.
Absolutely. And of course, the city closed down the only hospital in Southeast where women could have a baby. That was closed down. Maybe
they closed the Columbia Hospital for Women. They closed DC General, the only public hospital. And now, as you just said, there's nowhere a woman can give birth outside of Northwest in the nation's capital.
Absolutely, that's right. And we fought like hell to not make that happen, but they closed it. And that was the DC Department of Health. Ambrose Eilanes Jr., welcome. What are your comments about this situation with Unity?
Well, certainly, thank you. Thank you so much for having me, Joni. As usual, I feel like I am following in your footsteps because I learned so much from you. I'm kind of in the position of not only being a Unity patient, which I am, a Ward 7 resident, but I'm also a health advocate. So I learned so much from you just in my health advocacy. And so two things I would like to point out on the patient side. I've had experiences at Unity, and most of the experiences that I've had have been very good experiences. I've had, of course, some glitches, but for the most part, I've had good care. And so I'm really praiseworthy in terms of the care that I receive and continue to receive at Unity. On the health advocate side, I'm also advocating and have been for communities east of the river, and we suffer some of the highest disparities of chronic diseases in the country. I mean, if Ward 8 were a country, it would be the highest. They would have the highest incidences of diabetes in the Western Hemisphere. If Ward 7 was a country, it would have the 6th highest diabetes rate in the Western Hemisphere. And the causes of death, you're talking about really heart disease and cancer. That is at the top of the list east of the river. So Unity clinics become such an important piece of the healthcare system that it's really troubling to hear that the workers are not being treated the way that they need to be treated, because it troubles me as a patient, because when I walk into a clinic, I want to be able to be cared for, and it doesn't diminish the quality of the care, but I also, like many others, don't want to be treated by a physician that may be under stress because of the way that they are treated by Unity. And so that speaks volumes, and so we really need the city to get involved to really help and make sure that the workers, that the physicians, that the nurses at Unity are getting equity. That is so critical, because if they're treating patients, it's important that they can treat patients with a frame of mind that says that they're being taken care of as workers. And that's important for patients to feel comfortable. And I just wanted to make sure that I said that, because when we get into the health disparities, and I know Kimon mentioned yesterday about the life expectancy rate. I mean, I served on the Commission for Health Equity for 2 terms. We came out with a health equity report that talked about how there's a 21 year difference between those that life expectancy difference between those that are in Anacostia and those that are in Palisades. And this is across the city. This is something that has been pervasive. And so even when you talk about diseases and chronic disease, there are generally 4, pandemic, epidemic, endemic, and chronic diseases are endemic in the Black community. And what that means, endemic specifically, endemic means ongoing and pervasive. And so we need the infrastructure that Unity provides, and the other FQHCs, as well as the urgent care centers, because we really need that in order to begin to address some of the chronic conditions that are pervasive and ongoing. So I could certainly wax poetic, Joan, because I talk about this all the time. I talk about it in my sleep. My wife would tell me, but so it's something that's near and dear to my heart, because the health if we are not healthy as a people, and I know that only 20% of what happens at the doctor's office is really contributing to our healthcare condition. It's really the 80% outside of the hospitals and outside of the FQHCs and outside of the clinics that we really have to deal with. But it's still important to have that strong infrastructure that Unity provides. And if Unity is not providing that infrastructure by supporting its doctors and physicians, then we're in trouble.
And we are in trouble indeed. I think one thing that hasn't been made clear is that there was a major change in the leadership of Unity, I believe, in the last year or two, and that is what has made some changes in the quality of working conditions for the physicians, and that translates back into the patients. So let's jump in with Dr. Chapman for a bit, and we're definitely going to be hearing from Roach soon in the second hour when we talk about the jails. Let's make sure that Dr. Chapman gets a chance to jump in here as well with regards to what is happening. Of course, we know that there's a major challenge across the country with our healthcare system, but Unity has taken a hard hit with this change of administration, and it's injured, it's suffering, and it needs help, outside help, to survive. Dr. Chapman, what would you say in general about Unity and what's happening?
So again, Joni, I think we need to really listen to what Ambrose said about the 80% of health outcomes propagated outside of the doctor's office and hospital. So homelessness, African Americans are 13% of the population, but 37% of the homeless. So that's a figure right there that puts our community behind the 8 ball. There's no way you can get around that. Taking care of people who are not living in a safe environment costs much more. They don't have the contacts with telephones all the time, or internet, transportation, etc. So if you could imagine if the providers at Unity are taking care of patients who primarily are on Medicare, Medicaid, or no aid, that they're seeing a disproportionate number of people who are homeless or in living in unsafe environments. That in and of itself is going to increase the time and effort. It's also going to contribute to mental health issues, anxiety and depression. So, when we talk about mental health, many times people think you're talking about schizophrenia or a real severe mental illness, but anxiety and depression is impacts about 50% of our patients, which means that that is a barrier that has to be overcome. So when the providers are talking about trust, they're really talking about reaching that patient and getting past that anxiety and depression. So all of these things are compounded. And then, of course, those stressors lead to what I call community toxic stress. And when you're dealing with that conundrum, it also leads to substance abuse. So you have all of these factors involved. And that's why they're saying that it takes more time to deal with these patients in order to gain their trust, to get them to do what you're trying to accomplish. Working with Ambrose and Roach and Rhonda, we are working on what we call a community-centric approach to healthcare. People always talk about patient-centered, but community-centric, if you could think of an African village, our approach is to change that model so that the community is involved, just like a village, in terms of surrounding each other with help and support. And this is really the start of it. This is the kind of model that we want. It's very much different from the corporate system that has been described. But once I think we can get the money and the resources, and that means control of housing. We talk a lot of as much or more about housing than medications, because just having a safe housing changes the cost, reduces the cost of care, and the safety factors and all of those other things that I mentioned about mental health and substance abuse. Just having safe housing would be a major step. So we know that homelessness has increased in the district since COVID, at least 12 to 14%. So again, those are the factors that the providers are talking about.
Absolutely. Not to also mention healthy food, access to food. And Rhonda, if you want to jump in, and we may want to hear from some of the providers before we leave them at 7. I just want to bring in Malcolm X, though, for a relevant quote when Dr. Chapman talks about community-centric. One of my favorite quotes of his is, "When I is replaced by we, even illness becomes wellness."
Absolutely. And Dr. Chapman said it so well, Joni. We oftentimes, when we're talking about medical care, we're not thinking about the social determinants. We're not thinking about the realities of the housing crisis, the homelessness, the drug addictions, and or I should say substance abuse addictions. And also the understanding of, when I look back at this crises, we call it, for this Unity Healthcare matter, we've got only 34 full-time providers remaining at Unity Healthcare.
Is that true?
And it's 34 is what this latest literature from the union represents. And it says just 14 are clinical primary care providers. And so thinking of what Keisha and both Ambrose explained, they were very happy in their care and their relationships. But how in the world can Unity, in their policy and advocacy on their website, it references that Unity is more committed than ever to making our families and communities healthier? When you have families that have social determinants and depending on the continuity of care that is necessary in these medical relationships in order to provide the types of foundations that many of the patrons that they see have to deal with, it's very interesting. And One other statistic I want to throw in there, since we're talking about the understanding of what our citizens are dealing with as we go through this crisis of care with unity, and for them to understand what this represents. As Dr. Chapman mentioned, African Americans are 13% of the population, but even in the matters of chronic kidney disease, we represent 35%. And as Ambrose mentioned, the life expectancy for us, or for Black or African American citizens, are lesser than it is in other parts of the city. So for unity to not show responsibility in these union representations and negotiations, it brings up a very hypocritical representation of what they share in the public way. The citizens that they provide services for depend on them to be responsible and to do the right thing by these physicians. I can't say that enough. We are already grappling with so much in the matters outside of the medical arenas that our medical professionals and the systems that contain them really must be responsible. And we're not seeing that. And we're not seeing a district government that steps in to provide the level of oversight to protect our citizens. Yes. So thank you very much.
And we'll be getting into that in the second hour. We could not get not one city council person who would agree to come on and talk about this crisis at Unity. Unity needs support. It needs involvement from the community and more. We only have a few minutes before the 7 o'clock hour. Did any of the providers who were with us this hour want to comment before we leave you? And we're going to be speaking with other providers.
Yeah. Yes, I wanted just to kind of piggyback on what everybody was saying, especially about mental health. One of the things that, one of the policies that the administration, Dr. Boyd and Tracy Harrison's, they have really pretty much destroyed the mental health department. Like, there are very limited mental health providers in any of our clinics. They had transformed into like a consult kind of service issue that they can only be like a patient can only have like 3 or 4 sessions with the patient, which for our patient population, like we have said, they're immigrants, they're our homeless populations, they're our most marginalized population. Like 3 or 4 sessions of a mental health with a mental health clinician is totally not enough. And then the other thing that I wanted to mention about the social justice aspect of it is that Dr. Boyd has come from from McKinsey. She was a consultant for McKinsey, who provided the consultant. It's a group, McKinsey, that usually they focus on maximizing profits, trying to minimize the amount of providers that they are. They're a very big consulting group that is very famous for being detrimental for the providers and for the patients. So she comes from that kind of atmosphere. And they also provided a 3-year strategic plan. So I don't know if that's what they're following, and that's why there has been the changes and the policy changes that have been made. I don't know if that's where it's coming from, but we just want to be able to see our patients. We want more time with our patients. When Dr. Boyd and Tracy Harrison, what they want to do, right now we're scheduled to have 24 patients a day, 12 patients per sessions. When we told them that we want to see less patients, have more patient access, their answer was their proposal was for us to see 30 patients a day, which is totally unrealistic and totally goes against what we really want, because we want to have that access to our patients. We want to be able to address all these problems. What they were talking about, the social determinants of health, is that our patients have a lot of issues that cannot be solved in 15-20-minute appointments. And we want to have that continuity. The urgent care is important for our patients, but having that continuity over the long-term helps, because we can kind of reiterate the importance of diet, the importance of medication adherence. We can, like Mr. Tracy was talking about, educating about vaccines. So having that continuity and that preventative medicine aspect is what is helpful for our patients, that long-term care rather than just urgent care, which you need now and we'll maybe see you back in like 6 months, which is what the current administration is kind of doing right now. And is being led by people that I don't know if they're unwilling or unable to do it, but Tracy Harrison and Dr. Boyd, all they talk about is access, but it's not access to good quality care.
And thank you. You are Dr. Esteban Rivas, right? Physician.
Correct. Yes. Correct. I actually work at Upper Cardozo, and I'm sorry to talk about Upper Cardozo. It used to be and busiest clinics that Unity had. Right now, because of the exodus of providers, there's very little providers left at that clinic. The amount of patients that come into that clinic is very low compared to what it was. It's pretty much a ghost town when you go there as compared to what it was. Mr. Tracy can kind of talk about it as well. But patients are very sad that there aren't any providers to be able to see patients, and just having that wait for like 4 or 5 months to be able to see somebody is too much.
Well, we're going to have to do something about that and come together to bring more attention to what's happening at Unity. You're listening to WPFW 89.3 FM. We are in a 2-hour special. We're walking into the second hour, reversing the healthcare access crisis for the underserved in DC, radio form on Unity Healthcare Clinics, and we're going to be talking about the DC jail. This is a 2-hour special, co-sponsored by WPFW and the Union of American Physicians and Dentists. This is Joni. You can hear me usually on Mondays at 10 a.m., and I'm joined by my co-host, community activist and wonderful person, Rhonda Hamilton. And we're going to be jumping in to our second hour. Before we do switch over totally, Jimmy, Tracy, did you have any brief comment about what Dr. Rivas just said about Upper Cardozo being a ghost town these days? Maybe he's no longer there, so we need
No, I'm so sorry. I'm sorry, Joni. I'm here. I'm so sorry. Yes, I just wanted to thank you for having us today. It is, yes, what Dr. Rivas is talking about is that it is really important for a full-time primary care provider to be a reasonable job to have. It's just a part of the structural problems that we've been talking about on the panel. But in America, or at least in DC, to the extent that we can help it, we need to make primary care a priority. And we need to make it so that the people who are willing to do that job make sure that they can do it for a full-time job and provide. And right now we don't have that. It's untenable. It's an unreasonable amount of work, and people have so many other options. They can work at hospitals, other places. We need to prioritize and make sure that working at primary care, especially at a clinic like ours, is a reasonable, wonderful job to have and not a unreasonable burden.
Absolutely. Thank you very much.
Thank you.
Tracy, nurse practitioner at Upper Cardozo, and Dr. Esteban Rivas, physician at Upper Cardozo as well. And of course, thank you for the patient that jumped in, Keisha Keith. We're going to move on, and maybe our wonderful engineer can play the song that we have for the 7 o'clock hour.
Dreaming of a city where all of us will always know when we get an illness, there's a place where we can go. We won't pay a penny, we'll get treated decently. Dreaming of a city where hospitals are free.
And that was Pam Parker singing, and she was with us yesterday on the radio with Imone and Ambrose, Dr. Chapman. We're moving into our second hour, and the first part of the second hour, we're going to be talking about the DC jail. And then after that discussion, we will spend the last half hour talking about what can we do? What is to be done by the community? What should the city council be doing? What should the DC government be doing? That'll be in the last half hour. But let's start with what's going on at the DC jail. And unfortunately, some of these things that we're going to be hearing are not new. So who better to speak about what the history of problems at the DC jail than Roach Brown? Merry Christmas, Roach.
Hi, and happy Groundhog Day to you.
You can be with us.
How you doing, Joni? Thank you.
You were here with us, but you are. So
Thank you. Thank you. I want to say first, thank you for what you're doing and for everybody who is participating and joining. This show is a lot of passion and commitment because we're talking about people's lives. And a lot of folks are interested. And for you, Joni, and Dr. Hamilton to coordinate this thing, it's needed, it's appreciative. And baby, we're talking about, hey, it's a line in the Bible that says, when you do this for the least of those, you do it for me. And everybody here is doing that work. And I just want to say thank you. But I came through a historical view from the jail is that in 64, I went into the old DC jail 56 years ago. But I ain't but 35. You know? Plus tax. So we didn't have medical care back then. And most disturbances or situations or conflicts in correctional institutions, the number one or two issue is medical care. Mm-hmm. And when we don't have competent, qualified medical care, that's a public safety issue because the prison can go off either way, and it affects the community. You know, and these kind of things that having people who are there who are providing this service and care is needed. I don't care if you like Unity. I don't care what name they call them or disunity. It don't make no difference to me. I know it's like I had a toothache on a Friday and was transferred to another prison. And when I got to this prison, they said the dentist had just left. And I had a toothache and it was on Friday. And they said, he's coming back Monday. I said, well, I got to have a toothache for the whole weekend. And when Monday came, I was 55th on the list. So I had to wait till Wednesday. So I had a 5-day toothache. So I know what it's like to be suffering themselves in situations where you need help and you need medical attention. You know what I mean? And them folks who are providing that need to be compensated because they are providing the service to help take care and provide a public safety issue. And I keep saying public safety because if they don't, they will strike out. Like was the gentleman, the doctor who gave the historical point of view in terms of people got work they have to do and provide. And this is the kind of situation where if they don't get it now, they get it some other kind of way. They're reaching out when they spit on somebody or do a little foolishness. But there's a couple of things. One is, and I'll get off here briefly, Joni, the Supreme Court ruled in a case called Estelle versus Gamble that prisoners are the only ones in society that have a constitutional right to medical care. Repeat, Estelle versus Gamble. It's a Supreme Court decision that the only segment of society that has a constitutional right to medical care are prisoners. So we're talking about a constitutional right violation because if you don't have staff to provide this medical care, that's a violation of the Constitution. You know what I mean? Because somebody got to be there to provide that care. And these folks, I was confused. You're talking about service providers. To my folk, we're talking about doctors, dentists, technicians, medical staff, and personnel who've left. And if you go to a school and the principal come into school on Monday morning and 25 teachers didn't show up, what kind of shape you think that school will be in at 12 o'clock?
My Lord.
You know.
Wow.
So there's been all kinds of litigation against the Departments of Corrections, federal and state, about inadequate, insufficient medical care when they changed from government run healthcare and turned it to the private sector. And there's a couple of situations where the medical care and healthcare dropped off deficiently because of it's private. It was cost effective. They had to make it cost effective in order to run these facilities, these companies, and that resulted in deterioration of medical services. But I don't care what deterioration happened. If you got a doctor and you got a toothache, you want to help. And if you're in a cell and you can't get out, you want somebody to help take care of whatever ailments you got. For these folks that go risk their lives and go in and they work in our communities, they go in some neighborhoods that a lot of you folks wouldn't even go into. And they providing first in the line medical care. So let's support each other. And I guess, again, as the Bible said, when you do this for the least of those, you do it for me.
Amen.
Thank you, Roach Brown. Well, Roach, we want you to jump into with the two physicians we're going to talk to now who work at the DC jail. Let's welcome on board Debrica, physician's assistant at the DC jail, and Dr. Danelle Fincher, who's a physician at the jail as well. So let's start with are both of you on the call? Dr.
Yes.
Yes.
Okay, who wants to go first? How about let's start with Debrica Posey, physician assistant.
Yes. Thank you so much for having us. Just to kind of give you a little background on the DC jail, we currently have about a little over 1,700 residents. Our pre-COVID numbers was about 1,800. So we're pretty much kind of back to where we were pre-pandemic. With that said, we have about 7 to 8 kind of chronic care or primary care providers. Unfortunately, I don't think any of those are actually full-time primary care providers. They all split their time between the DC jail as well as other community clinics due to staffing. And just for a little bit of kind of nomenclature, outside of our chronic care or primary care, we also have our sick call providers. Sick call providers would be, we see patients for kind of your low acuity things that you would typically go to an urgent care for. So if you hurt your knee, ankle, you woke up with a cough or sore throat. Those are typically the things that sick call would see you for. Sick call is a 24/7 entity. So we see patients every day. Up until a couple of months ago, we only had about 3.5 full-time sick call providers. We had a couple of providers leave. And so sick call, just to kind of give some idea of how many patients a sick call provider could see, because residents do not have to, of course, pay to see us, they can request an appointment every single day if they so choose. And I told you at the beginning of this conversation, we have a little over 1,700 residents at the DC jail, and that's a combination of both sides, according to statistics published by the DC jail in April of this year. So our sick call day could be, some days are great. Each provider that is scheduled may only see, 25 patients. But a lot of days, as of late, have not been so great. Last week, we had several days in a row where we had over 150 sick call appointments scheduled with only 2 providers working to cover those appointments. And based on our national standards, we are supposed to see them within 24 hours. We are not supposed to cancel visits, even if the person's been seen for the same thing multiple days in a row. So as you can imagine, sick call, everyone in healthcare is overworked. Everyone is tired. Sick call is extremely tired. I will say that there has been a little bit of hiring as of late, but unfortunately, our HR department isn't the best. So oftentimes a lot of people are hired, but it takes so long to get through the HR process. And I'm not talking your standard, 2-3 months of credentialing. It's well past what would be acceptable time to get people in the door. And of course, people have bills. People have things that they need to be doing. So they're not going to wait around 4, 5, 6 months to finally get in the door for their orientation. Circling back to chronic care, as I previously mentioned, we have about 7 or 8 chronic care or primary care providers taking care of these 1,700 plus patients. And unfortunately, everyone doesn't really take that great care of themselves. So we do often see patients that have a multitude of comorbidities. And anyone that has a multitude of comorbidities, you can imagine that that visit is going to take a while. And that's not even always a face-to-face visit, because there have been plenty of times that providers are calling pharmacies because, people don't always know what medication they're taking, calling people's parents because they, their parents are the one that knows what they're taking, even as, a 50-year-old man, calling mental health facilities, personally faxing release of medical information to other jails or other entities to try to bring it all together to make sure we're taking the best care of our patients. So when you have all of that going on with so limited staffing, it is extremely difficult to do your job effectively the way that you would like to. Nobody, or most people, don't want to halfway do their job. We want to provide the best care that we can. And the elephant in the room is the safety at the jail, as you can imagine.
Mm-hmm. Mm-hmm.
We don't always have an officer with us, as we should when we go down to the units to see patients. We are often, I won't say often, but there are times when residents do expose themselves, or, we're living in a time of a very large opioid crisis. So people are withdrawing. And so I'm not sure if you've had much contact with people that are withdrawing. They're not always the most pleasant. So that could pose a safety risk. We are just generally spread extremely thin at the DC jail, as well as in the community, as you've previously heard. Dr. Fincher, did you want to jump in there?
Fincher, you want to jump in?
Yeah, I think Debrikia did a great job sort of talking about how understaffed the jail is. And I just wanted to piggyback on what she said about safety. A lot of us work for example, part of the reason I came to Unity is I wanted to work at the jail. I wanted to provide care to, the most forgotten and warehoused members of society. So I willingly, went into a jail setting, especially as a woman, knowing that I'm going to be taking care of inmates. And I know there is some inherent risk with that. But the thing is the providers who do make that decision, that they are willing to take the inherent risk of working in a jail, they need to know that their employer has their back. If they're going to be putting themselves in these situations, they need someone to have their back. And one example quickly was just, I was assaulted by a patient. I really needed to leave, and I was not allowed to leave. So I stayed and continued to provide medical care because I was the only MD in the building after being assaulted by a patient. I don't remember the medical care that I provided because obviously I was not in the best, mental space to provide that care. And I think it's completely unfair of the patients that I took care of that day because I was not at my best and Unity did not have my back. And because of that, these patients got worse care. Another thing that Debrikia sort of touched on is a lot of the providers, whether they're sick call or community or primary care providers, they work both in the community and at the jail. And so one of the things that's really unique and I think wonderful about providing care in the jail is that the people making medical decisions are making the same medical decisions in the jail as they do in the community. People are getting the same care and the same standard of care in the community and in the jail. And I think there's a lot of other facilities that can't say that. And so Unity really has this amazing opportunity to link people as they return to their communities and link them to care. And we are failing miserably. And that's just another way that we are, especially when it comes to connecting people with substance use disorders to opioid treatment programs in the community. connecting people who have really complex medical conditions so that they can see a primary care provider and get reconnected to care once they leave the jail. And again, Unity has, if we were fully staffed, if we had the right amount of people, we would be able to provide such an incredible service to really help these people, but we can't. And so again, Unity is failing some of the most underserved and needy patients in this entire area.
Thank you very much, Dr. Janelle Fincher and Dr. Debrica. Is that how you say your name, Posey?
Debrica.
We have about 10 more minutes with you, and let's see if some of our other co-hosts can want to jump in.
Yeah, I wanted to, Joni, just thank both Ms. Fincher and Ms. Posey. You guys have done a very well job depicting just what the conditions are there. And as I listen at you both speak, I just first and foremost want to thank you for your service. It brings to light the relevancy of having workplace safety. I can't imagine entity and these overpaid executives not understanding the role that they put you guys in. The standards of care are too low in these instances, and we are often advocating for citizens that you guys service to have access to impactful care, life-sustaining care. And Ms. Fincher, she just phrased it so well, failing miserably. And any reputable organization would not want that to be, the representations of their care to the citizens, failing miserably. How else can you provide a higher standard of care when you yourself are in jeopardy? And as I said at the top of the last hour, what does it look like when the professionals that are hired to care for you find themselves seeking protections and their mental capacities violated? And so I can just thank you both for your services. And Joni, thank you, along with all of our other community activists and union representatives for bringing this to the forefront. We must do better, and we will do better. I want to invite Roach and Dr. Chapman to come back to the conversation. When you hear these lovely professionals speak about conditions at the jail, what comes to mind for you all? Roach?
Roach, is it
Dr. Chapman?
Well, let's hear Roach. I want to ask.
There you go. Yeah. You said what comes to mind?
Yeah,
present day.
I'm wondering too, Roach, is this situation with the DC jail, is it different from the situation jails around the country?
It's a crisis, Joni, and when you got men, especially right now with the temperatures in the 100s, and you're locked in one of these little steel cells, and you got these big iron doors. There's no fan, the air conditioning ain't working, no cold water. It is misery on top of misery. So, and to be denied medical treatment or mental health, physical, whatever, hey, it only exacerbates the problem and make it dangerous for everybody inside, the staff, the medical personnel, because they got to deal with these folks. And these folks, when they strike out and do all them bad and negative things, it's their way of expressing themselves because they can't take it no more. So we need to make sure that we get use all the resources we got, Joni, to help this. Because I was suggesting that we get the medical schools in the interim or whatever we can work out. I understand it's a 4th year practicum. I don't know if that applies to the medical school, but some of the medical personnel could help out in a crisis like this. This is a public safety issue, and we're talking about when it's folk need to help people and they need to get paid for the work they do. DC is an expensive city to live into. It's expensive, and to be underpaid and overworked, that's illegal and unconstitutional. You know what I mean? So whatever we can do to help support this project, and I'm dig this, Joni. Ain't nobody perfect. Unity got its problems like everybody else. The Supreme Court ain't nothing, nobody, no entity and organization is asshole clean. Everything got its problems. But when somebody's doing what they're doing to reach the least of us, of those, and they're doing it, hey, we got to support anybody that's doing the right thing to help somebody to get along in life. I'm on board with it. And Merry Christmas.
Absolutely, Roach. And again, you can hear Roach every Tuesday morning at 10 o'clock. The first Tuesday of the month, you can hear him for 2 hours from 10 to noon. Before we move into our last half hour, Roach, let's also get Dr. Chapman's comment. But Roach, I wanted to ask you, is there any jail facility in this country that is actually somewhat of a model? I kind of doubt it.
Joni, I've been dealing with prisons since 1964, and there's no prison, jail, and not only in this country. There's a couple in Sweden and Denmark, but there's no institution in America that the healthcare, because it's almost it's difficult. It's like you're talking about 25 clients or patients a day. You're looking at 50 to 75 or 100 clients, and you only got one doctor or two doctors. I mean, it's always been understaffed and underfunded. And that impacts on the direct medical treatment, and that impacts on the staff that runs the facility because they're on the front line, and they're subject to be sorted out of the folks' frustration, etc. So this is something that, hey, we need to work on this and stay on top of it and make sure that these folks get this thing going. Because we got to get some people over there, Joni, to help out because folks are dying in these cells, and it's hot. Can you imagine being in the cell right now and it's 99 degrees and no fan and no air conditioning?
I really want to highlight and reiterate something Mr. Roach said when he was talking about the heat in the cells and people advocating for themselves. Mm-hmm. I worked a lot in urgent care, which is basically the mini emergency room. So overdoses, stabbings, the worst of the worst in the jail. Uh-huh. A lot of times you would see people who were yelling and screaming and jumping on top of things, and you're trying to figure out what's happening, but you realize they experience a symptom.
Yeah, they're acting out.
Short of breath, sweaty, something because it's hot in their cell. Yeah. They think, I'm in jail. No one cares. I'm going to die alone in this cell. The only way I can advocate for myself is to make a scene.
There you go.
Get someone to listen to me. Mm-hmm. And so imagine you're a provider who's already seen 50 patients that day, and this person comes in yelling and screaming because it's their attempt to advocate for themselves. How do you respond to that? When you've already seen 100 patients that day, it's really hard to be able to de-escalate that situation when that's really what the patient needs.
Yes, you're right. It's damn near impossible. It's difficult. It's impossible. And again, prisons have always been traditionally underfunded and understaffed. Right. And because of all this new diagnosis of diseases we never heard of before, you know what I mean? They didn't have all this mental health, psychological counseling, diabetes, dialysis, and all this kind of stuff. If you got sick, if you wasn't bleeding or sneezing, then don't come in. You know what I mean? And the doctor used to see us in a freight elevator. There wasn't no medical room. You had to go in a freight elevator to see a doctor to be examined. And he wasn't a doctor. He was a physician assistant, and he spoke German. So, and I didn't speak German, so you're going back to your cell. That was the medical care.
We have a minute or two left, but I think Roach put up an interesting idea whether there could be medical students that could provide additional service.
Yes.
Yeah, and I wanted to ask Dr. Chapman to weigh in because we on the community level have been, speaking about the low standards and wanting to be a part of the solution. I know Dr. Chapman has some thoughts. He recently had some conversations with folks over at the jail. Dr. Chapman?
Yes. So, Rhonda, I was given a blind call by a couple of physicians in the jail, letting me know that there was a position open for a medical director for what's called the MAT program. That's the Medication Assisted Treatment Program for opioid use disorder. The physician who was there was an extraordinary young man. I met him. I know his background. 2 years ago, the DC jail was one of the few in the country that began treating opioid use disorder with medication. the medications that we typically use, there are 3 FDA-approved medications, are the only medications that a person going into the jail would be taken off of. You would never imagine taking somebody off of their diabetes medicine or hypertension medicine, et cetera. But lo and behold, 2 years ago, the Substance Abuse and Mental Health Services Administration, through the Department of Behavioral Health, got a grant to provide methadone and buprenorphine and maybe injectable naltrexone in the DC jail. So currently there are over 400 residents on these medications. So with the medical director gone for 2 months, part of that job description was to help connect those individuals with providers in the community, as well as taking care of them while they're in the facility. So just as Dr. Fincher mentioned, there's a monumental task involved. And if these individuals are not connected to providers in the community, that means that there's a good chance, almost 100% chance that they're going to relapse and create this revolving door. So when you think about all of that has been discussed, I think we really have to wonder who's making money off of this. We know that there are people in the U.S. Congress that have investments in the jails. So they want to keep those jail cells full. There might be some folks on our city council that have some investment in DC jails because of the fact that none of them showed up here. You would expect them to be interested in this conversation because we're really talking about a public safety issue and a revolving door. If you come out of jail, and I've had 3 inmates under 40 discharged, referred to my office. Of course, they did not have insurance because their Medicaid had been cut off. 2 of them were homeless, and one of them had some mental health issues. So we're really creating this environment that keeps money flowing for this prison industrial complex. And the fact that there seems to be a reason or rationale not to treat people because people are making money off of this. So it's a travesty. The fact that most of these individuals are in the district are African Americans. And of course, when you're talking about substance abuse, you can't separate that from AIDS, hepatitis C, and other infectious diseases. So we've worked very hard with the faith community to get them involved, and actually got a grant from the Department of Behavioral Health. And we had 4 individuals with access. It took them 8 months to get access to the DC jail to go in and meet with inmates that may be coming out to connect. But it's been very fragmented because of all of the issues that we've talked about, the lack of personnel in the jail to connect with. And we're not talking about just connecting them to medical services. We're talking about connecting them back to the community. So to get the faith community involved in this has been a monumental task. And that's part of our community-centric approach that Rhonda's talking about. And Roach can tell you more about the housing issues, which is a major issue. We have to have some place for that person to go other than where they came from, because frequently they're going to go back to the same environment and relapse all over again. And of course, getting jobs is another critical component. So we as a community have to stand up and have to demand because these are our neighbors. These are our family members. These are our friends.
Absolutely.
Absolutely.
Dr. Edwin Chapman, and you're listening to WPFW 89.3 FM, Jazz and Justice Radio. We're in our last half hour of this 2-hour special Reversing the DC Healthcare Access Crisis for the Underserved Radio Forum on Unity Healthcare Clinics and the DC Jail. And again, this is a program co-sponsored by the the Union of American Physicians and Dentists, representing many physicians around the country. And I'm here, Joni. I'm usually here. You can hear me every Monday at 10. And I'm blessed and thankful to be here with Rhonda Hamilton, co-host for this evening. And we're going to spend the rest of our time talking about what is to be done. And Dr. Chapman gave us 2 marching orders when we began planning this program. And he talked about the importance of mobilizing and involving the community, number 1. Number 2, somehow getting the DC government and the DC elected officials to find out what's happening, support what's happening, and do something about it. So let's start first with talking about mobilizing the community. And I think with this section, we want to definitely hear from Kimon again. And Rhonda, you can jump in, and probably Roach too. But
I think that's wonderful. As you said, those are great questions. And I believe that with mobilizing the community, we're able to actually tackle both, because the reality is that there's big money being made, Joni, on the backs of Blacks and marginalized DC citizens, as well as our incarcerated populations. And the reality is that I read an article that said DC was the 5th healthiest city.
What?
Exactly.
No,
exactly.
they're lying.
So we don't get these citizens talking.
We're one of the most unhealthy cities.
Well, I blew a stack when I saw that.
That's if you just count the wealthy white people.
Well, if we just go down the list of all of what Ambrose and Miss Keith and Dr. I'm sorry,
crazy. But
Fincher and Miss Posey said, that we all know better. We know better. But the reality is that if we don't get the community mobilized and speaking out and showing up over 26% at the voting polls, then we're going to keep getting what we've been getting. And the reality is that, as Dr. Chapman pointed out, somebody's making some money off of this, because otherwise, how could it be? So I believe that what we have to do is we have to make sure that forums and conversations such as this are able to be brought to the level of the individuals that it's impacting. Unity sees over 80,000 patients, and a lot of them are poor and marginalized. And when you look at DC, when we talk about poor and marginalized, we're actually talking about roughly over 100,000 of the district residents actually identify with poor and marginalized. And in that number, we also have about 68,000 African Americans living below the poverty line. And so the efforts and the energy and the intentions have to be in place consistently. But I think it has to start with properly educating our citizens. We have these wonderful forums, but the reality is that the turnout is not always as great as good as it can be. And so we've started to host town halls. We've started to hold the elected officials accountable for showing up on the community level to understand this. I mean, with 98% fentanyl on the street and open air drug markets daily, the reality of being able to change the status quo means that we've got to go where they are. Kimon, will you jump in? Because I know that you have a lot to say.
Yes, Kimon has a lot to say, but let me, and we definitely want Kimon on, but I also want to mention that we have another activist physician. She's active on many issues I can testify, and that is Dr. Sugarman. She's also, I think, in Upper Cardozo. And so our focus now, Dr. Sugarman, is how do we get the community involved, and how do we get the elected officials involved to turn this situation around? And unless you want to wait and hear from some of our other speakers.
No, can I talk now?
Absolutely.
So I just want to set the stage a little bit. I feel like I'm a dinosaur. I'm one of the few full-time primary care doctors left at Unity Healthcare. I'm full-time at Upper Cardozo. People shake their head like, well, what are you still doing here? And the work, I love the mission. And just before I talk about activism, this morning was really the quintessential morning. I was in working the walk-in clinic.
We're having some trouble with the Zoom.
come at 7 o'clock. Oh, can you hear me?
Now we can, but we may be having some challenges.
Okay. Patients are told, come. Okay. Can you hear me?
Well, you're coming in and out.
I'll look around a little bit. Okay. Can you hear me now?
Yes. Now we can, yeah.
Okay, I'll try not to move. Patients are told, come at 7 a.m. and between 7 a.m. and 8 a.m., maybe you'll get appointment for some time during the day or come back another day. Most of the providers have left. The place is a ghost town. And we have a provider who we just gave a going away party for. She was here for 24 years at Upper Cardozo. Who is going to see her patients now? It's really, really dire. And, we want our patients to mobilize, but our patients face many challenges. They have insecure housing. They have multiple medical illnesses. They're working multiple jobs, taking care of family members. So, some patients can mobilize. And some patients can't because of the challenges of their lives. So we need everybody, patients, community members, healthcare professionals to mobilize. And where are our elected officials? Well, we have to we have to make noise to our elected officials, the DC City Council, until they take action. And we can't let up until they do. The city has many healthcare agencies on house people, all kinds of different agencies dealing with healthcare. And, we need to make noise, make trouble until there's action. But I'm telling you right now, with Upper Cardozo being a ghost town, the clinic is generated by insurance reimbursement. So we can't maintain an empty clinic. It's the patients and the insurance payments that pay the bills. So, the clinic would have to shut down. And then what happens to the 80,000 sick and poor people? So yeah, we have to make noise. We have to make good trouble. Why do we have DC Healthcare Alliance? DC Healthcare Alliance is, takes care of the poor and the underserved, the undocumented. We don't have DC Healthcare Alliance because people were polite, right? We have DC Healthcare Alliance starting from the year 2000, I believe, approximately, because people made noise. Well, that's what we have to do now to keep Unity afloat. And these executives who can, not only are they getting high salaries, but they're paying lawyers ridiculous salaries to bust up our union. How is that okay? That money that could be paying the staff fair, decent wages is going to consultants, is going to fancy law firms to bust the union. And if people say, oh, well, you're in trouble because of the union, no, we've unionized because we were being treated so badly. We were told to increase our numbers where we were already seeing huge numbers of patients. We unionized because of the unfair demands. And I'll tell you, I've been mistreated many times in my life by management. The reason I'm on the radio tonight is because the union gives me protection. The union allows me to speak up, and you can't just fire me at will because I'm speaking up and speaking on behalf of our patients. So we need to speak up, speak loud, make good trouble, and until our workers and our patients are treated with justice.
Absolutely. Great point.
Kate Sugarman, and we agree with you, Rhonda and I. I want to make sure we have time to get both Ambrose and Kimon in, because one of the issues we're questioning is it just by accident that none of the city council people are involved and that none of the let me ask you this, Dr. Sugarman, what is the DC Health Department doing? Back in the day when I worked there, we would come and work with you. Has there been any involvement from the DC Department of Health?
I don't know. Maybe Dr. Rivas knows. I believe Dr. Henderson, I'm not sorry, I believe Councilmember Henderson wrote a scathing letter to Dr. Boyd about the conditions. But I don't know. Other than that scathing letter, I don't know what anybody in the DC government has done.
She might have written a scathing letter, but she wouldn't come on the show. Let's go to Kimon.
No, just to mention, the board was notified. The board of directors was notified about all these terrible things going on, and they turned a blind eye. So the board is aware. How could they not be aware? I don't know. But we specifically told the board, and they chose to ignore us.
Okay, Dr. Sugarman, I want to make sure we get some of our activists in who work on these issues all the time. Kimon, what do you say? And Ambrose, which one of you would like to go first?
I take it. Thank you, Ms. Sugarman. But I assure you this that we don't have to just lobby our elected officials. We can replace our elected officials.
All right, recall. All
Yes,
right.
in our last election, Muriel Bowser had less than 50% support of the city, and that's why we have ranked choice voting, so we can have people that actually reflect us. And as I said earlier, I'm running for Congress myself to challenge our 34-year incumbent with Eleanor Holmes Norton. So we don't have to accept the status quo; we can change it and challenge it. I just want to acknowledge that something that Dr. Chapman was talking about. He said, in terms of people who have vested interest in maintaining the status quo, they are gatekeepers who are put in place deliberately to make sure nothing fundamentally changes. We need to understand that. And so, no, it's not just by happenstance. This is by design. This is public policy. And something that Ambrose had mentioned earlier, that 80% of our negative health outcomes happen outside of the doctor's office. So I saw a great documentary, and I want to put this on everyone. I'm gonna put it in the chat for everybody, but for our listener audience, it's called "They Are Trying to Kill Us." This is about the food and the poisons in the food and how they have directly marketed junk food to our communities that contribute to that 80% of negative health outcomes. And what I learned in that film was that there is a direct correlation between people who own fast food companies and also have investments in pharmaceutical companies that are providing medications that these people become dependent on after those diets take effect. So there is a lot of joogie boogie going on here. And we need to connect the dots on that. And we need to have a level of political maturity to understand that. So I'm welcoming this conversation. I hope that we will continue to scratch beneath the surface and continue to pull back the layers of this onion and not in a woe is me, distraught and throw our hands up. But I think that we are the ones we've been waiting for. And, the greatest power is convincing people they don't have any. And I think everyone here could collectively contribute to some solutions and some outcomes that can challenge this and turn this thing around. But we're going to have to educate the public. We need to come together with a media campaign. We need to put our heads together. So hopefully this is the first of many conversations to move us forward. And I hope that we can take advantage of the time that we have now, the fierce urgency of now.
Absolutely. Transitioning our citizens from victim mode to activist mode. Very well said.
Activism. Let's get Ambrose in here, because in our planning discussions for this program, we talked about the fact that is it just that the city council is being lazy, or there's some of us who've been here for a while know that there are sometimes things going on that we don't necessarily know about. We know that they were planning to close DC General for a long time before it really became public. But so we don't exactly know what may or may not be going on around this issue with Unity, but we need to be thinking about it.
Absolutely.
Ambrose?
One of the things that we need to be very vigilant about is how hedge funds buy up healthcare companies. That is extreme. They're not only buying up healthcare companies, they're buying up prisons. And they're changing policies. If you are someone that is assigned to an MCO, a managed care company in DC, they assign you your primary care doctor. Okay, so I was assigned a primary care doctor at Unity. And that's the case for anyone who is signed up with an MCO, a managed care company. They're assigned a primary care physician. And so that like Dr. Chapman said, it is about the money. They want to maintain the money flow by doing a number of different things. One of those things is keeping people sick, even though they profess that they want to keep emergency room visits low, but emergency room visits are how hospitals make their money. And so, as long as if they're talking about keeping the doors open because you get the reimbursement rates, that is healthy for physicians to be able to take care of patients. They need those doors open. But we talked about the jail earlier, and I just want to say I wanted to make sure that I said this, because I will get to what we need to do as far as the community is concerned as well. But in the DC jail, I'm a proponent of food as medicine. And in the DC jail, the food contract is by Aramark. And if you are a proponent of food as medicine, you got to look at what is happening in DC jails, where 62% of people never or rarely have fresh vegetables, and 55% rarely or never have fresh fruits. 70% reported that the food was either spoiled or rotten. And this doesn't lend to good health either. So to me, it's all a mixture of what is happening in terms of what I think is the genocidal nature of our government, the genocidal nature of our country, in terms of what is happening in all aspects of life, including those that are incarcerated, and including those that are in community, feeding sugar into our communities as far and as wide as they can. And so this whole thing, we've got to expose and we've got to educate our community about this. Access to and the pervasiveness of sugar, which is a food issue, is still a health issue. And so when we talk about educating our people about what's happening with unity, we've got to go into the communities. We've got to go amongst the patients that are unity patients and tell them that the physicians and that the nurses need their support to call your council person, to call your mayor, and to bring attention to this, to have community forums like this one, have open forums in the community, and let people know exactly what is going on. We did a lot of that work when they were trying to build the new hospital. And we did that. I did that for 2.5 years, trying to build community support for a level 3 trauma center, which they finally did. But it took a lot of advocacy work. It took a lot of going to community meetings and talking about this issue. And that's part of what needs to happen, going into the community, talking about these issues at community meetings. Don't just have forums, but go to the people.
Am I on the air? We have 6 minutes left, folks. I want to make sure that people have a chance to give their final word. Dr. Chapman, in 1 minute, what would you say your final statement is about how do we change this? How do we organize the elected officials and the community to care, to get involved, to do something?
Take to the streets.
We have to stay together, support each other, and vote. I think someone said earlier that we can vote these folks out, and that's what's going to happen. We have enemies within. This is not a black or white thing. We have enemies within our community who are just as destructive as Donald Trump.
Yeah.
That's a final word. That's final
true.
word.
I wonder, Roach, what would be your final statement?
We need to take direct action. Take to the streets, as Ms. Sugarman said. Voting them Rascals out, we can vote them out, but right now we need to take to the streets, get the churches, get the community involved. This is a crisis. Folks now don't have medical care. They're already making inadequate wages. They ain't got enough money to live off. Even if they get a prescription, they can't afford to pay for it. I mean, come on. So this is a crisis. We need to take to the streets, have a mass rally in front of the mayor's office. I don't care what it is. People are dying because there's lack of treatment. There's nobody there to provide the services to them. You know what I mean?
This is correct.
Yes, absolutely.
On September the 2nd, the people are doing just that. On Labor Day, they're taking it to the streets, and we're going to provide Joni with that information so that you guys have access to that. We need to do just that, and we need to be strategic. The meeting.
We can go in front of the mayor's office, her house. Let's go in front of a house. This is urgent. This is a crisis.
It sure is.
Can I jump in? One thing too is
one point. I just want to make one point. The median age for citizens in the district is 34 years of age, which means our millennial population. So we need to be strategic about mobilizing our millennial voices. Absolutely. Go ahead. Thank you.
Let's hear Kate Sugarman.
Yeah, and you can go on social media, look at the group Climate Defiance. Disclaimer, it's my son. But it doesn't take a lot of people to make an outsized disruption. And you don't have to get arrested. And, if you call out, like people said, call out the mayor, find out, events that she's going to, or find out where the members of council are going to, and shame them. And it, it doesn't take a lot of people to make an outside disruption. And if you don't want to make the disruption, then you take it on your video. So you can video another person on your phone, take your phone, make a video of somebody embarrassing our our elected officials. They work for us. And then you post it on social media and you can have an out and shame them because, 80,000 people are going to risk going without health care and shame the people who work for us, our elected officials.
Absolutely.
And they full of jiggy boogie.
Yes, they are. And I would say, Dr. Sugarman, but I also would agree with Roach that we really need the masses of people. And normally
direct action. Let's take it to the streets. We got to stop it. We're talking and people are dying.
You need to win it in the court of public opinion. You're absolutely right.
That's right. Oh, we have about 2 minutes left. Kimon, you want to get your last point in again? If he's still there.
Yeah, of course, I'm still here. I'm up here posting on social media as we talking, and I'm getting a lot of text messages, a thumbs up on the content that we are sharing with the public here today. So I'm looking forward to where we go from here. Again, this is Kimon Freeman. That's Freeman, the number 4, Congress.com. Freeman, number 4, Congress.com. And when Dr. Chapman said there's a number of Black people in office who are as much as a detriment to our community as Trump, I think that's gospel. We need to acknowledge that. Just because, we said this before, everybody my skin folk ain't my kinfolk. And we need to understand that this is not about racial politics. They're killing all of us. And we need to understand that this sick care system is cradle to the grave oppression. It starts from the school lunches and the commercials. America is the only country that allows direct to consumer pharmaceutical marketing. They got a drug for everything that you possibly can imagine. And the doctors are not trained to acknowledge the role that food plays. Ambrose brought this up, and nutrition plays and contributes to our sickness. They don't talk about that. And lastly, I was in Cuba this past February, and a lot of people don't know this, but Cuba has medicine that pretty much eliminates diabetic amputations. But America would not allow that treatment to be made available in the States. And I'm quoting from the U.S. ambassador who told me that was to protect U.S. business interests. Therefore, it's in U.S. business interest to keep chopping people's feet off like Kuta Kinte rather than give them the treatment that they need to prevent diabetic amputations. And now we have dialysis centers around here like liquor stores. And so we need to acknowledge that this is an emergency. We have a health crisis when we have over 2 decades disparity between life expectancy on your zip code in the same exact city.
For decades.
Absolutely.
It's
unacceptable.
It's unacceptable. We're getting a lot of texts. You're right. People are saying, awesome platform, great job. I'm saluting everyone on the show.
And let's not forget that the undertone of this is that the violation of DC citizens' human and civil rights are happening as a result of these healthcare disparities as these corporations come forward and make money. We've got to address the civil and human rights violations.
And with that, Rhonda, you got the last word. Thanks to everybody. Thanks to the Union of American Physicians and Dentists. Thanks to Roach. Thanks to Kimon, Ambrose, Dr. Sugarman, all the other providers. Thanks to Carrie Lane, who is the union rep. And thanks to you, the listeners. We're gonna make a difference. We're gonna stick together.
Sure will.
Let's hear the last song by Lucy Murphy and Friends. Thank you, Kalia, very much.
Are turned away. The system won't provide for the ones who cannot pay. Go tell it to the nation on Capitol Hill and everywhere. Go tell it to the nation. We all deserve health care.